So stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up.
You will understand why. So as a young boy, as a 7-year-old, I always knew I wanted to participate in healthcare. I didn't know what part of healthcare I wanted to participate in, but I knew I wanted to be involved in taking care of people. Some of the reasons are my personal experience. You know, I lost my dad when I was 7. So my dad had just finished his PhD, and lost my dad. I was 7 years old. So I understood immediately the pain of human suffering as a small child. I was raised by my mom, who's an educator, a teacher, and I ended up at University of Nigeria in Nsukka. Any lion here? Red lions and lionesses? There you go. Which, again, I am biased, is the best pharmacy school in the world. There are other pharmacy schools, right? It's University of Nigeria and then the rest. So I graduated pharmacy with all the interruptions, all the strife. Eventually we graduated sometime, I believe 1998. And I went and did my internship at National Orthopedic Hospital in Iwobi, Lagos. I've been a lucky chap in my life. Because at Iwobi, I had some phenomenal mentors. I worked with some phenomenal pharmacists. Ms. Obono, Ms. Ibekwe, these are just some of the pharmacists I worked with who, as an intern. And graduated pharmacy school, landed at Iwobi. These wonderful ladies taught me a lot as a young pharmacist. And after that, I went to serve. I served in Lagos at the Federal Ministry of Health, the Infectious Disease Hospital in Yaba, did my service. And then right after my youth service, I was looking for a job. I was still serving, and back then we didn't have WhatsApp or internet or cell phones. This was 2000, I believe. But we had newspapers, and I remember I was on one Danfo bus. You guys know those Danfo buses, yellow Danfo buses. I used to ride those things every day. And I was on the Danfo bus, and I bought a newspaper, and in the newspaper was an ad for a job, SKG Pharma, hiring. I didn't know anything about SKG. I didn't know anyone at SKG, but I applied. And at SKG, I went for the interview. And what I did was I bought the bag. I bought a little, you know those kind of bags reps carry. I bought one of those, and I dressed up. I went for this interview. So I looked like a drug rep. I mean, I didn't know the person about repping. But I guess it impressed the people who interviewed me, and I got hired at SKG. So I started my career after youth service as a drug rep at SKG Pharma. Again, I was lucky. I had some wonderful pharmacists I worked with. Mr. Okaba, who hired me, he was a GM at SKG back then. Fidelis Majuku, there were some wonderful, wonderful mentors who, again, nurtured my career as a young pharmacist and a drug rep. I was a rep in Lagos. I was one of the reps who started the line Primpex. I believe that medication is still around. Primpex, King Tonic, Wayton, all the lines of SKG drugs. I repped those drugs. And in 2003, I made the decision to leave Nigeria. I left Nigeria and I immigrated to the United States. I first went to Canada and then to the United States. So I am licensed in Canada, I'm licensed in several states in the United States. When I got to the US, I realized that pharmacy, the way we practice in Nigeria, when I practice, was totally different from the way the rest of the world practices pharmacy. I recall my first day in a pharmacy, so when you go to the US, you have to do all these exams, which I did, and then before I got licensed, they make you do intern hours, so I was an intern. I remember the first day in the pharmacy, I show up in the pharmacy and they hand me a prescription. And the pharmacist says, well, he's an intern, so he told the techs, he's an intern, let him take over, because interns are supposed to be higher than techs, and know what I'm doing, right? I knew pharmacy, I could read the prescription, I could read zip codes, but there was a computer. And I was supposed to take this prescription and somehow get into this computer and somehow get the medication dispensed. I didn't know how to type. That was a problem. So here I am, because when I went to school, typing was not for the smart ones. The smart people go to pharmacy school. Then when you need to do your project, you pay the people who go to pharmacy school, who finished maybe primary 4 and learn how to type. So I didn't have that skill. And here I am in Atlanta, Georgia, in a pharmacy, picking the keyboard. And I'm picking the keyboard with one finger at a time. And the pharmacist says, no, put the prescription here. He thought the problem was I didn't know where to put the prescription. I held it in one hand, I was speaking with the other hand. He said, no, put it here, that's what this is, so you can type freely. He didn't understand that if he gave me 10 hands, it wouldn't help. He didn't understand that wahala, the man was facing wahala. I was about to start sweating. I tell this story to say, I went home that night and I realized that to be successful, I had to learn how to type. And I downloaded a program called Typing to the Backend, and I started learning how to type. And about a month, I was a proficient typer. I could type fast. I could blaze with a keyboard. I say this to say that part of what will continue to make pharmacy thrive in Nigeria are the pharmacists in this room and the pharmacists that practice in this country having the humility to identify when you're not competent. And when you're humble, you can self-identify your gaps. And then you can fill those gaps. And when you fill those gaps, you become more competent and better at what you do. And that is the trajectory of my story. It's about identifying gaps in my person, and then filling those gaps, and it has led to continued promotions within my corporation. That is how I achieved every single role. Now, I have been in the United States practicing for 20 years. The pharmacist has been no longer than I have been, and those 20 years, by the grace of God, I've done some very phenomenal things and challenging things that have very large scale and actually touch humanity. You know, during the COVID that intro, work with the CDC and Operation Warp Speed, and to deliver 200 million vaccinations in President Biden's first 100 years in office. When we started our work, no one knew how it would be done. No one had ever done it. But set a goal, we picked a number, and we had to do it. The very interesting thing is that when I remember getting on the first call, there were representatives of the CDC, the government, Operation Warp Speed, and there were 6 of us on the call. This is the core team that was going to work on this strategy. And we're introducing ourselves. Here I am, Chidebelu. Lady from the CDC, Tolu. The person from Pfizer, who was the manufacturer of the vaccination, was Ade. So you got 6 people on the call trying to solve the most challenging problem for the United States at that point. 50%, half of them are Nigerians. Half. And that's the talent that we have. And we did that, and we delivered those doses. But the core strategy was built by people from this country who, for whatever personal reasons, have left and developed other competencies and skills that were able to impact humanity in large ways. So, I know my slides are up. So that brings me to the slides, to the presentation of the keynote. My slides up? There you go. So the challenge we have, right? The challenge we have, and the problem that unless you can't solve problems. We have to be brutally honest with ourselves to be able to solve problems. Our healthcare system is broken. Now, healthcare system around the world is generally also not very, it's broken. Go to countries that are similar to Nigeria and have established healthcare businesses that are thriving and making a lot of money. I just give you a couple of examples. So drug trade, the pharmacies in Mexico are, the first time I went to visit Mexico at a work level, the pharmacies are no different from Nigerian pharmacies. You go there, there's a girl behind the counter, you tell her what you want. She's not a pharmacist, she's a sales girl. You ask where's the pharmacist, they say, he's coming. You went somewhere, you went to the restaurant. She asks what you want. If you want 2 amoxil, 3, 5, it doesn't matter. They cut in and give it to you. No difference. Same practice. But we went to Mexico and bought a chain of 40 stores and turned that around. These are stores that were just struggling to survive. That is a $40 million business today, revenue. So it's possible. Why do I know it's possible again? In the last 5 years, I have personally been approached by 3 different companies at 3 different times to come and lead a company in Nigeria to do healthcare, pharmacy-driven healthcare. One is a South African investor. I didn't want to leave my job at that point, but they wanted to come start up a company and be the CEO, and they have a lot of money to invest. I want to invest in Nigeria in healthcare, pharmacy. 3 companies, 3 different times. So it does work in Nigeria. Chile, another country, no different from Nigeria. They sell drugs the same way, they even worse. In Chile, the pharmacy, for all of you that have stores, your front door would be what we call in Nigeria burglary proof. You can't go into the pharmacy. The sales girl is behind this cage. Because they have a high crime rate, people go in there and rob them. So you go to this door, and through the cage, you tell them what you want. Even for the OTC, you point, and they bring it to you, put it in a bag, and you give them the money, they give you a product. But again, we bought stores, not a chain, we bought individual stores and made them a chain. And again, it's a thriving business. I believe $30 million revenue. Still selling it through the same burglary proof. Still operating the way the local economy operates. So, I say this to say, healthcare delivery can work in Nigeria if you do it differently, and it can drive money. You can make money doing it. Here's the solution. High level. It's a front door to a reimagined healthcare system. So think about a healthcare system that doesn't exist today. Community pharmacy is a front door. Because to get a patient better, it's not just the drugs you're going to give them or sell to them. There's a lot more that goes into that. Part of what drives up costs in healthcare is care navigation. One, the patient doesn't know what they need. So they might go see a surgeon when they don't need surgery. They might go see a doctor when they don't need a doctor. So they need someone who understands healthcare, who can help navigate that patient into all the things you need to get better. And the best positioned person is a community pharmacist. Because community pharmacists are usually embedded in the community, accessible to the patient, and the patient shows up, and you know what they need. They don't know what they need. You know what they need. So you can help them navigate care. The trick is that if you build a value-based care model, that is all part of controlling costs and making money for yourself and making the patient better. And we'll talk about that. Define quality measures come into play. So, I don't know, those of you in community practice, which is most of us here, this is ACPN. A diabetic patient sometimes doesn't know where they're chasing. Last time I went home for Christmas, I try to go home. I come to Nigeria quite often. I bring my family. I have 2 kids. I love them so much, so I bring them to Nigeria every year so that they make sure they were born in the United States. But I need them to know they're Nigerian. I need them to know how to kill chicken, how to pluck mango, how to roll nubo. and all those things. So I bring them home frequently. Every year they're in Nigeria, sometimes twice a year. And last trip, we didn't know, like a woman shows up, she tells me, for those of you who don't understand Igbo or translate, she tells me, I'm sugar, which means I have diabetes, basically. I have the sugar disease. I said, okay, what else did they tell you? That's it. They told me to take these pills. And I look at what they gave me. They gave me metformin. But right there and then, you have a patient who has a diagnosis, but has no idea what the goal is. Has zero idea what we're trying to solve for. That is what makes making money in community practice difficult. Because now the pharmacist has reduced themselves to a commodity trader. Because at that point, this lady knows she's diabetic. She goes and buys a metformin. Well, at that point, if I'm the patient, I'm going to buy the metformin from wherever I can get it the cheapest. Because there's no differentiator. What's different? Patent medicine stuff, it doesn't matter. I was just told to take this pill. So at that point, you reduced our entire practice and knowledge to a commodity. The problem when you commoditize pharmacy is that you don't make money on it because you're just selling a product. And the patient will always defer to the product. I told you guys I'm a trader. If it comes to can get the price lowest and make the slimmest margin on it, that's where the patient goes. So if you run your business that way, you're going to be competing with people who can always bring the price lower than you because they don't have your overhead. A patent medicine store will always have lower overhead than you, so they can take lower margins and they will outsell you. Now, in a value-based model, what will occur, which is what we build in countries like Mexico, is that the same woman, I will tell her, you have diabetes. And she says, what next? I will say, there's something called hemoglobin A1C. There's a test we're going to do. That test becomes a goal that you and I will partner to get you to. So I will test our A1C, and it will be 9 or 10. And I will tell her your A1C is 10, and she will tell me, what does that mean? I will say, the goal is 6.5. I'm going to help you get to 6.5. That will be our goal for the next 3 years, or whatever year I put on there. And for that, you're going to pay me. I haven't sold you a product, I haven't sold you a commodity. And then she's going to tell me, well, I don't want to pay you. Then I'm going to help her calculate how much she spent on healthcare last year. How much you spend? How much you buy these drugs every month? All the inconveniences of diabetes. Then if I'm smart enough, I can also add the complications that are coming in the future. I will tell her how she will be amputated. I will tell her how she will lose her sight. I will tell her how her kidneys are going to shut down. I will tell her all the things that happen to diabetic people when your blood sugars are uncontrolled, right? I'm walking her down how this movie is going to end. And I'm helping her understand the cost burden that she will have to bear. And I say, I can reverse all that. This is what you're going to pay me. And you're not going to pay any other person. I'm now responsible for your care. Everything. So this is what we call value-based care models that we build. And when you enroll the patient into the panel and they pay you, usually it's what we call PM per month, you can fix it. Whatever it is, 50,000 naira a month, 10,000 naira, it doesn't matter. You design a model where it benefits the patient because they're spending less than they spent last year. And I check your A1C. We set a goal, and then I can start the care delivery process because I know I can do that better than anyone else. Now, in that case, you've established a panel where you can buy the drugs from me because I also sell products. But I really don't care if you want to buy it somewhere else. I'm telling you, pay me this amount of money. I'm responsible for your total care. If you want to go outside and spend more money, sure, knock yourself out. But you can just come to me and get the drugs. Now, there's no patent medicine dealer I need to compete with because they can't do what I'm doing. What I'm doing is managing the patient to a goal. She knows the goal. I know the goal. We have a timeline, very defined metrics, and we're both getting there. It's the simplest way of starting this. So I'll give you value-based care is For those of you who drive, if you take your car to a mechanic and they tell you that, the gearbox is faulty and it's 20,000 naira, you pay them 20,000 naira, and they fix it and you go back home and they say it has a problem, you're going to take it back to the mechanic, right? Are you going to pay him again?
No.
You already gave him 20,000 naira to fix the gearbox. He's responsible for fixing the gearbox. Until you get it right, I'm not giving you more money. So smart mechanics should figure out how to fix a gearbox. The cheaper he can fix it, the more money he makes. Okay? The customer is happy, he's happy. If it's a mechanic that's not good, he'll keep trying and trying. Before he knows it, he spent more than 20,000 that you gave him. And you're not giving him more money. If you're me, I give you a dime more. You have to fix my gearbox because I paid for it. Because I paid for the value. I'm not paying for what you're doing. I'm not paying for transactions. That is how you have to think of pharmacy practice. That is how we've innovated healthcare across the globe. It works. It works, and if you stop thinking of yourself as a product dealer, but rather someone who adds value and takes care of patients end to end, you can monetize that. It's a slow process to start, but once you start, it's like, the flywheel. It's slow to start, but once you start, it gains momentum, and you will understand how driving significant revenue. At that point, you don't need policy to protect you from patent medicine dealers. Anytime I hear pharmacists clamoring for policy, I didn't say policy is not bad, but policy ain't going to save you. If you're dependent on policy to save the profession, we're doing something wrong. If we need laws, no, we need to differentiate ourselves and make sure no one else can do what we can do. A brain surgeon doesn't need policy to stop anyone from doing brain surgery. They just need a skill set. They're confident that they're the only ones who can cut into your brain and do the surgery correctly. You can go anywhere you want to go. You can go to patent medicine and do your brain surgery. They don't need any policy to stop it. Go! But they are confident that because they have a certain skill, only they can solve that problem for you. So the patient is forced to go to that brain surgery when you have a brain problem. Pharmacy has a differentiated skill that we need to leverage. If you leverage it effectively, you differentiate yourselves from patent medicine stores, and we don't need any policy. It's about, again, enrolling patients with chronic disease burdens. Usually it's chronic disease, setting therapeutic goals that are well defined, and helping the patient, managing the patient to that goal. The example I gave you with A1C, for example, what we discovered when we started doing this is that the patient shows, you check it the first time, it's 10. They come back next 3 months, you've been putting them on this drug. They come back in 3 months, you check it again, now it's 9. The patient is so ecstatic. Human beings like progress. Human beings like knowing what they're chasing. What is a target? When you don't have a target, you have patients who are not compliant to their drug therapy, patients who just buy drugs as commodity, they go to the cheapest source, because they don't know what they're doing, they don't know what they're treating. So you got to define goals. The good news is that most chronic diseases, it's easy to establish goals. High blood pressure, you can establish goals. With systolic and diastolic blood pressure. Diabetes, A1C, you can establish goals. So you can establish goals for most chronic diseases. So the vision here with value-based care is that the pharmacist has to be the leading provider in reimagining local healthcare and well-being for all. Let me tell you a little bit about why we believe the pharmacist is the best person for this. Remember, I work for a healthcare company. We employ doctors. We're trying to make money, so even though I'm biased because I'm a pharmacist, we don't really care about the practitioner we use. But in doing this around the world, what we found out is that a community pharmacist is best positioned to drive these models of care. Like I said before, they are accessible. They have enough training and knowledge. And if you as an individual pharmacist, you take the time, like I said, to be humble, identify the gaps in your competency and do the right thing to fill those gaps, you become a better pharmacist, a better practitioner. If you're not humble, you're not going to learn. Without humility, no one learns. Zero. So you got to be humble to identify the trainings you need. Now we're doing immunization training, right? Pharmacists are immunizing across Nigeria, which is one way to prevent disease, one way to prevent cost. and other training that you need to do this. And I mentioned earlier why I believe these models work in countries like Mexico, Peru, Chile, Nigeria. Is the last thing here, favorable regulatory environment. You know, I mentioned regulatory environment earlier. I'm sure some people thought I was going to badmouth our regulatory agencies. No, it's the opposite. Actually, value-based care is more difficult to implement in countries like the United States as a reimbursement model because they have a lot of regulations, a lot. I was in London last week visiting some of our Boots stores because we're trying something new. Boots were the pharmacists. So we have prescribing pharmacists, and we're doing the same thing in the UK now where you can go into a Boots store, see a pharmacist, get a prescription, fill the prescription, go home. We were negotiating with the NHS because it's a single payer system. NHS pays all the bills, just like we're trying to do with universal healthcare. It's one payer system in the UK. As a business person, I don't like it because it's hard to negotiate when the man is the one paying the bills, the man is the one writing the law, there's nobody competing, you take what he gives you, right? So we're in this negotiation last week. But that regulatory environment, the only reason why the NHS was listening to us is that we're reducing costs for them. They have a shortage of doctors in the UK. The patient pays about 70 to see a doctor, so it's £70 a visit. And we went in and said, a pharmacist can do the same thing for low acuity care, we'll take £35. So they listened because we're saving them a lot of money. They are the payers, they don't want to pay the bills. And they quickly put a law in place to allow pharmacists to do that. So now in the UK, for low acuity care, you can go see a pharmacist, we get reimbursed £35, and the pharmacist writes a prescription. And we have the data to show that the outcomes are similar to if you see a doctor, right? So it increases access and we get paid. Patient is happy, the payer is happy, the business is happy. But in Nigeria, what you had, I could set up that in Nigeria without the headache and the timeline it took in the United Kingdom. The reason being is our regulatory environment. It's easier. It's a lot easier. Has anyone ever given you trouble when a patient came and told you they have fever and you give them the malaria medicine? That's common practice in Nigeria, right? That is what took us 5 years to study in the UK. You know, in the meetings last week, I said, this is kind of what we do in Nigeria already. They say it's prescribing pharmacists. All of you here are prescribing pharmacists. Patient shows up, you diagnose, you prescribe, you dispense, bye-bye. So we have a favorable regulatory environment in Nigeria which makes value-based care easier to start up. And then finally, on the value-based care, the way you want to think about it is that the pharmacist supports the patient across the care continuum. So we're doing some work right now with Professor Larry Balley, I believe, to pilot some locations in Nigeria that will help, and we're going to work with ACPN, that will help community pharmacists who are interested in learning this model plug in and start understanding how this works. But let me make it clear. There are two outcomes that are important to me that I drive when I do this. Number one outcome is better patient care. The patient has to be healthier. We're trying to increase access to care for patients and get people healthier. The second outcome, these are the only two things for me that I care about. The first is patient outcomes, right? Patient gets healthier. The second is more money for the pharmacist. The pharmacist has to make more money. I have a personal saying, if you don't make money, it don't make sense. If the patient is diabetic, the patient has high blood pressure, because those are easily defined goals. Those are diseases that you can easily establish cost. You can establish how much the patient has been spending so that you can bargain with the patient to tell them, all this year, every day you're coming to buy this, buy that, buy this, buy that. Let's put you on this, I'll take care of you. All your healthcare needs, we'll put you on a panel, we'll define what that cost is, We define the goals that we're marching to, and we start providing care that way. It's a different mindset, different way to look at healthcare, but it's a way that we know works. And if you don't do it, somebody else will. Like I said, I've been personally approached to come and lead companies to do this, to do healthcare, and one of the companies actually, which they're still trying because they're well funded, what they wanted me to do, or the strategy that I shared with them, was to start acquiring your practices. Your practices. You guys own pharmacies, right? Yeah. It's the easiest way to spread. Done it around the world. So you come in, the value of your pharmacy today, I don't know these days how much it takes to start a pharmacy in Nigeria. 5 million? 10 million? I don't know. Whatever the cost. I can value your pharmacy, and I can give you money for that pharmacy, that you think you're getting a deal. You think you're getting a deal. This guy is foolish. He's paying me for this pharmacy. And I'll buy it, and I'll buy the next one, and the next one, and before you know it, I bought 100 of you guys, and I make it a chain, I put a brand around it, and I build value care models around it. And you will never be able, you can go start your own pharmacy somewhere else. You will never be able to compete with me, ever again. You will be working as a pharmacist in that chain if you want to survive. Or you can go take the money I paid you for a pharmacy and do something else. You can open meat pie store. But in pharmacy, you're not going to be able to compete. So I say this, and the money I paid you, in no time, I'll be making 5 or 6 or 10 times that amount of money on an annual basis. Because all I'm doing is taking a business model and putting it on your infrastructure that you have today. You're probably in a good community, good position, people already know you. In a neighborhood that people come to your store every day, put the right model on it, you make 10 times that money. Remember the change, I told you, one of the chains we bought in Chile was losing money. They were losing money. I think we paid $5 for that acquisition. $5 plus debt, whatever they were owing. Because they were upside down. So they were happy. But they started making $30, $40 million. So it's about how you do it. So again, it's a humility to say, this is interesting. Get out of your mind that it won't work in Nigeria, because it will. I hope that when we continue the work we're doing with Professor Bella and Co., and with ACPN, that we can bring pilot models that individual members of ACPN can plug into and start to learn how to do this and pilot this. Because the last thing I really would want is for Nigerian pharmacists to lose their practice to well-funded business people who form chains and really take your source of income, where you can have the opportunity to really make a lot of money. Because I know this country, I practiced here for 5 years, and this country is ripe for healthcare disruption, because there are 3 things we always look at, 3 things. When I go to any country, any market, 3 things. You want a country that has someone who's paying for the healthcare, and you can talk to that person. In Nigeria, it's a patient. The patient pays for it, so you're already there. In other countries, it's harder because maybe it's a government that pays or an insurance company. Here, the patient pays, and they're in front of you. The second thing you're looking for is a country that the regulatory environment is what I call loosey-goosey. It's not too tight, which is Nigeria. Like I said, so you can write your own prescriptions. So you've checked 2 boxes. The last thing I look for is where there are poor outcomes. The patient is not happy with care. The patient is not getting better. Again, Nigeria checks that box. The outcomes are not great. The patient is taking a pill, but they don't even know what they're taking it for. So you check the 3 things that I look for if I decide on countries to go invest in and build these healthcare products. Nigeria checks all those boxes. So I know this business, and Nigeria has a population. We send 1 pharmacist for every 10,000 people. To make any of your pharmacies profitable, they are profitable today, I'm talking about significant profits. You probably need a panel of 100 patients, 100 diabetic and hypertensive patients to start with. So if you think of 1 pharmacist per 10,000 patients, and all you're looking for is 100, not very hard to get there. if you start it the right way, learn it the right way, and build these panels and go into value-based care. It is what I preach because it's what makes money for pharmacists, and I continue to advocate for the profession. I love the profession. I had said this session, right, when I was thinking about a keynote speech, I don't want to come here and read a speech for you, because I care about pharmacy practice in Nigeria a little bit more than reading a speech to you. I wanted to have a passionate, heart-to-heart conversation of the opportunities that exist. I wanted to even take questions, because there might be some. But I wanted to have a personal conversation with this group. Pharmacists in Nigeria are super smart. Nigerians generally are super smart. Just let's be clear on that. I don't know any other country that produces the amount of smart people that go elsewhere in the world and do amazing things. Every time I interact with, the so-called Americans, but half of them are Nigerians. Right? Every day, you're interacting with some American. I have meetings with Americans, but then you look at the name, they're Nigerian. There's Nigerian here, Ayo, and she practices, she works for Walgreens. That lady created the workflows for all, what I'm talking about here, disease state management. That's what she does for a living. She creates workflows for disease state management. She writes SOPs for a company. She's building a healthcare business in the United States, where I think the projected value-based care is supposed to make $3 billion. $3 billion, and she's designed all the workflows for that. And she's Nigerian. America. Right? Just like they say, I'm American. I'm from the Navy. So I don't know what's more Nigerian than the Navy. So I hope this helps someone here, but I really need us to, again, reflect on our practice. So your takeaway here is reflect on your practice. If you commoditize pharmacy, you will always be frustrated. If you make your business a commodity, if you think people should pay you more for the same drug because you put AC, or because your sales girl wears uniform, or because you went to pharmacy school, I should pay you more for the same drug because you have a license. I don't know why I should pay you more. You didn't manufacture the drug. So your license didn't make the drug, right? And yes, you have AC, but I don't live here. I just want the drug. Give it to me. So why should I pay you more? So the argument, you will always lose that argument, because what you've done is you've commoditized pharmacy. We have the same challenge in the United States. Our dispensing stores, that's why we put in services. That's why we put in value-based care. Because if you just dispense it, it's a commodity. It becomes who can sell it the cheapest. So don't commoditize your education. Don't commoditize your knowledge. Do not. You're a pharmacist, you're a professional, you're into care delivery. The goal is to make patients healthier, live better lives. You could do it better than anyone else. You wrap that around the medications or products, but that's not what you're selling. What you're selling is a value-based care to get people healthier, and there's a premium in that for you. That's what I want us to leave this room thinking, because it's coming. It's coming to Nigeria, whether I like it or not. But I just want us to participate as it comes, as it happens. Value-based care is coming here. It's coming. And it's going to be pharmacist-led. We have a residency program that I'm partnering with a couple of people to build, so that we can start training pharmacists as they come out of a pharmacy school on how to think value-based care, how to change their practice, how to deliver care better, and then how to monetize it. Remember, all this is not about, say, two outcomes: get people healthier and make richer pharmacists. I want the next time I'm coming for ACPN, I want the car park to be filled with all your, which car do they drive now in Nigeria? Range Rover, the Lexus. Me, I drive in Austin. I'm from Nnewi, I'm local. I don't like fancy stuff. I've been trying to import Innocent to Chicago where I live, but they won't let me import my little Innocent car. So whatever car tickles your fancy, but I want pharmacists to be wealthy. Pharmacists are wealthy every other place in the developed world. Pharmacists are wealthy in the United States. You know, graduate pharmacists just fresh out of school, we start them at $140,000 a year. We give them a $50,000 sign-on bonus. When I give them that, it's not because I love them. It's because they're going to drive value and drive revenues for us. Because we've created these models that you need professionals to drive revenue, and then the company makes money, they make money. So pharmacists are a rewarding profession, but we've got to do it right so that we can earn more. And I absolutely believe if we do this right, a pharmacist doesn't have to leave here and go to the United States to make money. You can make money here. If we don't do it, someone else will. Thank you, guys.
Please, can do better than that. Thank you so very much, and we appreciate it.
Have our strengths and weaknesses. Oh, I have vision, oh, can't you see?
I believe that if there's any organization positioned to change healthcare in Nigeria, it is ACPN. Community pharmacists are the forefront of care delivery. They live in the communities where the patients are. They're the closest people to the actual patients. So access to care is the very first step to improving healthcare. The community pharmacist provides that access. Pharmacists are the front door to the healthcare system and the healthcare ecosystem. And an organization like ACPN represents all community pharmacists in Nigeria. It is a preeminent organization that can change healthcare in Nigeria. Absolutely believe that. So that's a very great question. So with drug abuse, right, the very first thing you want to do is education. The more you educate communities, especially if you can catch them young, if you can educate kids before they get into that teenage stage where they are prone to abuse drugs, you have a chance at reversing the pandemic. I believe, again, pharmacists who are knowledgeable in that space can play a role in partnership with the federal government on mass education campaigns for communities, going to schools, going to high schools, going to secondary schools to educate these kids on the problems of drug abuse. And when we talk about drug abuse, there's also a part of it that's recovery. So the people who are already addicted, drug abuse, we have to treat as a disease. If someone is already addicted to a medication, they should be treated like somebody who has a disease. And pharmacists, again, are well positioned to treat the disease of drug abuse in partnership with the federal government. So education, the government has to fund this. Pharmacists can play the role of educating, providing resources for patients who are already addicted, and really solving this nightmare of the problem. So our government has a lot to do with healthcare. I've been a healthcare executive around for 25 years, and I've seen healthcare delivery across the globe. There is no country that has successful healthcare infrastructure where the government doesn't play a role. In the United States, government funds about 50% of the healthcare costs. In the UK, the NHS is a single-payer system. The government literally pays for everyone's healthcare. So the government's role is funding healthcare. Nigeria still contributes a small part of our GDP goes into healthcare. That is unacceptable. The government has to fund healthcare. Healthcare can be delivered by providers, but the government has to fund the healthcare. So we have to, as a nation, agree that our care, our health is important, and we have to apportion a greater percentage of the GDP to healthcare. Healthcare and education really makes up a huge portion of GDPs of most developed countries. If you look at countries like the United States, Norway, it's usually healthcare, education, and then maybe defense. Right now, our GDP contribution to healthcare is still significantly lower than countries that are similar to us. So I just think government should spend a little bit more, open the pocket, spend a little bit more on healthcare, so that the providers can actually deliver care to the right way.
For the champions, stand up for the champions.